I appreciate you for joining us today for this valuable educational program. I encourage you to review all the other sessions. All of the sessions were designed with your well-being and that of your practice in mind. It is my pleasure to introduce our topic and the speaker for our program. As medicine has evolved, so has MRI. Recent advancements in technology have removed barriers for patients who could not have MRI studies before. This session will cover weight limits, contraindications, fast scanning techniques, and scanning patients with implanted devices. Please join me in welcoming Michael Mager, Director of Operations at the Radiology Clinic.
Hello, everybody. Thank you very much. As Marissa said, my name is Mike. I'm Director of Operations here at the Radiology Clinic. We are a physician-owned practice right off Shady Grove Road, offering wide-bore, high-resolution MRI, low-dose CT, X-ray, and ultrasound. And we talked about a variety of different things that we could maybe offer that would be of value to our provider community out there. And then kind of some low-hanging fruit jumped out because I think half of our day is answering questions about MRI and trying to get patients through this type of study that can be, well, they perceive as miserable coming in. So the first slide just is modern MRI, removing patient barriers, because ultimately that's what we want to do here is, providers, they order MRIs and various radiology studies, and we want to make sure we can facilitate care for the patients and make sure they're comfortable. So let's see, hold on, go to the next slide. There we go. So this, I think, is what people think of when they think of an MRI. I put some words down there that we hear every single day. I think probably when people think of MRI, it's lumped in with like, a cross-country flight or a root canal, something fun like that. So closed in, scary, loud, every time, people don't call in excited to have an MRI. They call and they're like, oh my gosh, I have to schedule this. My doctor wants me to have it. I don't want to do it. Can you schedule me? So our goal, in not just this, but whenever patients come into the practice, is to show them kind of the more modern MRI, because I use the word traditional MRI because when MRI started, and even up until about a decade ago, most scanners were very long cylindrical tubes. Typically, they were in basements, which made it even worse. They were very dark. There's no lights or fans or anything like that, and they lasted a very long time. So just going to cover some of the things that make it more palatable, and I can't say enjoyable, but help patients get through it. So claustrophobia, the number one thing that people have problems with in MRI is obviously claustrophobia. Nobody wants to be in a small space. Obviously, most people know it's pretty loud. We tell them ahead of time, but usually they've already done some Dr. Google searches, and they know all about MRIs and how horrible they are. But if you look at the image to the left, this is a more traditional MRI. As you can see, it's kind of up against the wall, but this is what's called a long bore MRI or traditional MRI. Unfortunately, it's dark in there. You can even down here, this is actually one of the coils. It's very closed in, and the whole experience is kind of entrapping for the patient. Hence the reason why probably people hate them. But if you look at the image to the right, this is more representative of more modern scanners in MRI these days. And the Radiology Clinic actually has this scanner. So, the traditional closed bore magnet is kind of dying out. Our magnets here are wide bore, and we know how much that means to people and how it helps them get through the scan. And actually, the wide bore magnets offer the exact same resolution and image quality as a traditional long bore. So sticking with claustrophobia, that's actually me in there, and I am 6'2" and 230 pounds. And I mean, I'm in there, both thumbs up. You can see how much room I have in there. It's illuminated in there. It's you know, there's nice fans, things like that. So the bore, the bore length, you know, the length of the tube is a lot shorter. It's roughly half to 2/3 of a traditional MRI, and the opening of the bore is a lot larger too. Traditional MRI is, you know, typically the oldest kind of MRI is around 52 centimeters. Um, some of the newer ones, including one that we have, is actually 70 centimeters. So you could fit quite a, you know, you could fit a few patients in there if you needed to. And once again, the third point, it still maintains that high resolution imaging of a traditional magnet. You know, if a patient is uncomfortable, honestly, it's going to ruin the exam. Well, it's going to ruin their experience. It might dissuade them from coming in at all if they feel like they're going to be uncomfortable. So we understand what that's like, and we want to offer the patient, you know, conveniences and niceties, even apart from just the size of the scanner, to help get them through the scanner. So here we offer patient's choice of music. You know, 90% of our scans, we ask the patient what kind of music they'd like to listen to and just play it for them there. They can listen to Mozart, or most people don't choose, you know, death metal, but they could. We do have circulation fans in there, so it's not so stuffy. As you saw in the picture before, we do have lights on the side. That way they don't feel like they're in a coffin. And even things like blankets, pillows, positioning sponges, things like that, they make a big difference, because if they're not comfortable, they're not going to do it. So, and also we give every patient emergency call bell. God forbid, if they need to bail, they know that they can get out. Another nice feature of modern wide bore imaging is the weight limits. Bariatric patients, they have traditionally had a hard time getting imaging. When I started in MRI, there was no such thing as a wide bore. All of them were very small. And even myself, when I went in, my shoulders were grinding against the sides of the magnet. The center when I started in, anybody that was above 400 pounds, they had to send them out to the local zoo in DC had an MRI scanner. So as you can imagine, that's just horrible. And it was horrible for the patients. It's horrible for the center. It's just a mess. So as you can see, the gentleman in that picture he has plenty of room. And that's actually a 70 centimeter bore right there. And some of the things that reduce barriers for bariatric patients are the larger bore is obvious. You know, it's larger, it's shorter, so patients feel more comfortable and they could fit in there. And the second point here, smaller coil configurations. The coils are actually what receive the image, or receive the signal from the MRI. And it used to be that the coils were huge. They weighed like 30 pounds and they were just horrible. You'd lay them on a patient and they could barely breathe, and we'd tell them to go in there and lay there for 60 minutes and hold still. But now, you know, some of the coils are the size of my hand. And actually, the smaller the coil around the anatomy, the better. So that helps people feel more comfortable. And they're also, you know, about 1,000,000 times lighter. Even our heaviest coil is only about 4 pounds. And also most modern, jumping around. Most modern wide bore scanners have a lot higher weight limit. TRC's MRI can facilitate patients that are up to 550 pounds. And another thing that helps patients is an expedient MRI. When patients come into the center, one of the first things they ask when we bring them back and talk to them about the MRI is, how long is this going to take? You know, last time I had an MRI, you know, oftentimes this is like 10, 15 years ago, they say it took, you know, 2.5 hours. I was laying there, I was miserable. You know, they told me to hold still, I was moving. Once again, just kind of a really long negative experience. So I included this little image here. This is actually a chest. You can see there's the heart there, there's the spine and the thoracic cavity and lungs. This was the first MRI image, and it was a chest in 1977, and it took 5 hours. And just so you know, we don't have Sudoku in there. They won't have time for that, but I just thought that was kind of neat. So MRI has evolved quite a bit, and especially in the past 10 years, MRI has just kind of, had light speed leaps and bounds. Some of the things that have facilitated faster scan times are just better and faster, processors. The better you can process the image, the cleaner you can, the more you can push it. Dedicated receive coils. Originally, there were no actual coils like we know now. Like I said, you could think of coils as cameras. So, for example, a wrist coil now is a small coil that you put on your wrist. It used to be that the coil was about the size. It was almost the size of the entire bore. So roughly, 50 centimeters. So it was pretty big. And that actually sent signal and received it. But now actually the scanner itself sends a signal to the patient, and we have very small receive coils. And that high signal with small coils just helps the image to move quicker, the process to move quicker. Higher channel MRI systems, in the beginning, it was just one channel, and you could think of a channel as the amount of information you can collect in a given period of time. So the more channels, the quicker you can go, the more information you can collect. And the systems range anywhere from 4-channel to 32 channels. We actually do have a 32-channel system, so it's awesome. Patients love it. One of the most important aspects of MRI scan time reduction is actually a technique called parallel imaging. Siemens calls it IPAT. GE calls it SENSE. But when you acquire data in an MRI, each line of data is like a strand of DNA. And if you cut that in half, a strand of DNA, theoretically, they're the same on each side. So whatever's on this side is going to be on this side. And the way that the scanner acquires what's called KSpace is the exact same. So what the scanner does, it actually acquires half the information and interpolates the other information with the knowledge that it's going to be the same. So these are coronal T2 shoulder images. This has no IPAT, no parallel imaging, and this has a parallel imaging factor of 2. The one to the left with no parallel imaging took 2 minutes and 6 seconds. And the one performed with parallel imaging took roughly a minute. So as you can see, this makes a big difference for patients who are already uncomfortable. They don't want to be there anyway. So if you can halve the scan time, and that's excellent. It's excellent for everybody. And as you can see, there's no reduction in quality. It looks awesome. Typically, the average scan time for an MRI at the radiology clinic is 15 minutes. And depending on what it is, something like a prostate may take a little bit more, and something like a lumbar spine actually may take a little bit less. So make sure I'm not pushing the time. Hold still. I'm a very anxious person. We get patients on the table every single day, and they say, I just want to let you know I'm a very fidgety person. I'm really anxious. I don't think I could do this. And so that's probably, 1 out of 10 patients. So, as horrible as that is to hear for an MRI tech, luckily we can kind of fall back on our technology to compensate for some of that. So when a patient moves, it causes a variety of negative effects. They're not good bedfellows. It causes image blurring. The patient's scan time is extended because we have to do multiple repeats and so forth. It's just a negative experience for the patient. And at worst, really, we could miss pathology. And I included a couple images here. This is a brain that orbits here. You see the eyes of patients, they're moving their eyes a lot, which is very common. The middle one is a brain. And as you can see where the brain is, but if there was something small, you'd probably miss it. And the one on the right is a foot, which is so blurry, like it's non-diagnostic. So recent advances in MRI have kind of made them they're not, motion and MRI will always be enemies, but maybe they're more like frenemies now. So there's a new method of acquiring radiology or MRI images. It's called a blade or propeller. It's the accurate technical term is radial case-based filling. Oops. So traditionally, you acquire if you had a field of view like this, you're acquiring bits of each piece of the matrix, and then you put them all together at the end. The way that radial case-based filling works is you can see right here, each one of these lines is acquiring data. And if you look, a lot of these lines bisect each other, intersect each other, tons of them. And because it oversamples that data, it can correct for information that's wrong in the first place because it has multiple data sets for that same point. So if you look at the image to the left, on the far left, this is a normal MRI, and unfortunately, we do see this sometimes, but this is an axial T to the brain. Patient's moving. It's not very diagnostic. You're going to miss anything small. You're going to miss MS. You're going to miss, possibly a small tumor or something like that, a small infarct. The image to the right, that patient is still moving, but it was acquired using radio CaseBased filling a blade. And because of that, it can oversample that data and we get a nice clean image. And we use this for all of our brains because that's typically the exam that every patient moves on. Patients with implants. This is always a huge question. We field calls about this from patients in doctors' offices every single day, at least half a dozen times a day. Who can have an MRI with what type of implant? And historically speaking, implants are a huge barrier for patients, especially if the radiology department, the radiologist who's ultimately responsible for MRI safety within the office is not familiar with kind of modern implants and MRI safety. But we've had many patients who have come to our office saying that, they got turned away from one place or another because they had a stent, because they have braces, because they had, a BB in their toe or something like that. But the truth is that the majority of implants are actually MRI safe, and they have been for about 20 years. As long as it was put in the United States, typically it's safe. I listed some of the more common ones there. I'm going to move a little quicker because I don't want to push the time, but you can see that, stents, heart valves, all those things are safe. There are certain precautions we need to follow. And I have a little detective there. The truth is that, good radiologists, good MRI departments are detectives for their patients. It's very easy for us to say, you have this implant or that, it's not going to work out. You're going to have to do something else. But, our job is to facilitate care for the patient, not to turn them away, because there's obviously a reason, you as a provider have ordered this study, so we're not going to just turn them away. We say, we don't say no, we say, let's figure it out. And sometimes we can't, but usually we can. And this is a big question. We literally get this every day. I talk at length with providers and patients. Are pacemakers and defibrillators MRI safe? And I put the answer is yes, and the answer is no. I worked at Johns Hopkins for half a decade, and I've scanned probably 500 patients with pacemakers and defibrillators. And the non-conditional MRI pacemakers, what's called legacy devices, they're actually all safe. Actually, all pacemakers and defibrillators are inherently MRI safe in the sense that you're not going to get thermally burned by them. The problem is that, and Johns Hopkins did a huge paper on this. It's actually, the link is at the bottom of this PowerPoint presentation, but a cardiac device, a defibrillator pacemaker, must be monitored by a qualified cardiologist or electrophysiologist during the exam. They need to be put into what's called an asynchronous or demand mode before the scan. They need to copy the settings pre, and when the MRI scan is done, they need to put those settings back into the pacemaker so the patient's safe. And also an emergency cardiac response team, someone familiar with cardiac emergencies, need to be present. So can it be done? Absolutely. 99% of pacemakers and defibrillators are MRI safe, whether they say conditional or not. They're all safe. But it's a risk that outpatient centers, honestly, such as ours, are not able to facilitate because we don't have cardiologists on site, monitoring pacemaker MRIs. So most of these patients do have to be scanned at a hospital. There's no such thing as kind of turning the device off and scanning it. Johns Hopkins does have a great program, and they do have, unfortunately, a little bit of a backlog too, because there's not a whole lot of places to do this. So when these patients come into our centers, sometimes an MRI is what they need. They have to have an MRI. All these situations are run by the radiologist. And we have to have a conversation with the provider and direct them to Johns Hopkins. But honestly, probably more than half the time, there's an alternate type of exam that will be acceptable and solve the question for what the provider is looking for. If they're looking for a fracture and they order an MRI, it might be that a CT is fine for this case. So that's a big question that we deal with all the time. So just wrapping it up, and I do really appreciate the time here, and thank you to Montgomery County Medical Society. It's really nice. You guys have done a fantastic job on facilitating things for our medical community, and I've been really impressed. I live by BWI Airport, and there's nothing like that I've ever seen in my years. So thank you very much to your team. At the Radiology Clinic, as I mentioned, we are a radiologist-owned practice. All of our reads are done by fellowship-trained radiologists. We do have 24-hour turnaround time. Staff's definitely less than 1 hour. And oftentimes, honestly, the reports are done the same day. If we find something, we're going to call the provider. We're not just going to let the patient leave. Something else we offer to our provider community: imaging insurance authorization assistance. We know that you're busy. Just send the patient our way. We'll take care of the pre-auth for imaging. If we have any questions, we can always reach out. At the end of the day, we don't want to put any roadblocks to patient care, which is the whole presentation is about removing barriers, and we don't want to be a barrier. So thank you for trusting us with your patients. If you have any questions, our contact information is there, and thanks for your time. And if you have any questions, I hope I didn't take up too much time. I probably did.
No, it's no problem. It looks like we do have one question in chat. Please address why MRIs are noisy. What's all the banging about?
Yep. So when I was in training, and I asked that same question, the gentleman who trained me said it's called the magnetic acoustic effect. And he said no one knows why it's noisy. And I was like, oh. So I told patients that, but that's actually not true. So I told quite a few patients that there's actually 3 pieces of metal inside the magnet. They're along the bore, and they're called gradients, and they create their own magnetic fields. And so you have the big magnet, which is the big magnetic field, and then these 3 gradients. And to turn the images and get different planes, 3D imaging, you're putting energy through these gradients, and the magnetic field that they're creating is causing them to pull off the side of the scanner, and they snap back in. So what you're hearing is actually these 3 gradients snap, and they're just moving very quickly and snapping on the side of the scanner. So it's kind of cool.
That was a great question. I know it's one I've been curious about as well. Looks like we don't have any more questions in chat. I guess if you do have questions, there is the email address noted. I'd like to thank Mike so much, and all of you for participating today. We welcome your feedback on the session and on all of our Physician Renewal Week events. And we look forward to seeing you all again soon, hopefully in person. Thank you, everyone.
Thank you.